All right, let's get right into it. If you've ever dealt with that sharp, just really stubborn pain in the back of your heel, then this is for you. We are going to break down the brand new 2024 Clinical Practice Guidelines for Achilles Tendinopathy. This is the absolute latest science on what's really going on, and more importantly, what actually works to get you better. You know that feeling, right? You're frustrated by an injury that just will not quit. You've probably Googled a dozen different things, maybe tried a few, but that pain just lingers. Well, today we're going to cut through all that noise and look directly at the evidence. The goal here is to give you a clear, science-backed roadmap for your recovery. So, first things first, what exactly are we even dealing with here? Let's get a really precise definition because, understanding the problem is always the first step to actually solving it. Okay, now what's so important here is the precision. The experts don't just call this heel pain. They define it very, very specifically. It's not just any pain. It's pain that's triggered by activity, think running, jumping, that kind of stuff, and it's located in a very specific spot, the mid portion of the tendon, at least 2 centimeters up from your heel bone. And this distinction is absolutely critical. These new guidelines separate Achilles pain into two main types. The one we're covering today is mid-portion pain. So if your pain is right down at the heel bone, that's called insertional tendinopathy, and it's actually treated a little bit differently. So knowing exactly where it hurts is your first step toward getting the right treatment. And hey, if you're a runner dealing with this, you are so far from alone. I mean, look at that number. The research shows that up to half of all runners will experience an Achilles tendon injury at some point. It is incredibly common. So if this is you, you are in good company. But how do you know for sure that this is what you have? Let's talk about how it's diagnosed. So how does a doctor or a physical therapist confidently diagnose this? Well, you might be surprised by just how straightforward it is. It's really less about fancy, expensive machines and a lot more about a simple, hands-on clinical exam. These are the 4 big keys right from the guidelines. See a pattern here? They're all based on your experience and a physical exam. Where does it hurt? When does it hurt? Does it hurt when I press right here? And maybe, is there a little bit of thickening? That's really it. A solid diagnosis is built on these simple, clear signs. And this is a huge piece of news for anyone worried about expensive tests. You usually don't need an MRI or an ultrasound right off the bat. The guidelines are super clear that imaging is saved for special cases, like when the diagnosis isn't quite adding up, recovery has stalled out, or if more invasive treatments are on the table. For most people, it's just not the first step. Okay, now for the part I'm sure you've been waiting for. We know what it is, we know how it's diagnosed. So what is the absolute #1 most effective treatment according to the highest level of evidence out there? Before I even tell you what the treatment is, just look at this. A grade A recommendation. In the entire world of clinical guidelines, that is the strongest thumbs up you can possibly get. It means there is a mountain of high-quality research backing this up. It's not a guess, it is the gold standard. And here it is, tendon loading exercise. It's not about rest, it's about work. The whole goal is to progressively and safely apply stress to the tendon to wake it up, stimulate healing, and build its capacity back up. And that key phrase here is as high as you can tolerate. You want to work right up to the edge of what's manageable to make that tendon stronger. Now, loading isn't just one single thing. It's a whole toolbox of different types of exercise. You've probably heard of heel drops, right? That's a classic. But these guidelines confirm that lots of different approaches work, from heavy, slow lifting to just holding a position. A good physical therapist is going to find the right type and the right dose of load just for you. This right here is a massive mythbuster. The experts explicitly recommend against complete rest. I know it seems intuitive to just shut everything down, but that can actually make the tendon weaker and even less prepared for activity down the road. The real key is to find a level of activity you can tolerate and then build from there. So, exercise is the star of the show, no doubt about it. But what about the supporting cast? Are there other treatments that can help out alongside a really solid loading program? Let's see what the evidence has to say. Okay, before we check out those other tools, it's really helpful to understand how the experts rate all this evidence. This is the grading system they use. Grade A is the gold standard, right? Strong evidence. Grade B is still pretty good, moderate evidence. And as we go down that list, the evidence gets weaker, or it's conflicting, or it's based more on just theory and expert opinion. So keep these grades in mind. Now, looking at this list, one thing might just jump out at you. Right there at the top with a grade B is patient education. Seriously, just understanding your condition, what it is, why loading helps, why complete rest doesn't, is one of the most effective supporting tools you have. It empowers you to stick with the plan. And below that, you see a lot of treatments with a may use recommendation and weaker evidence, like heel lifts or manual therapy. They can be helpful for some people, but remember, they are supporters, not the main event. All right, this next part is just as important. What doesn't work? Let's talk about the treatments that have really conflicting evidence or that the guidelines specifically recommend against, so you can avoid spending time and money on things that just aren't going to help. Let's look at two really common ones. For orthotics, whether they're custom or off the shelf, the evidence is so all over the place that the experts couldn't make a recommendation either way. But for night splints, the advice is crystal clear. They should not be used, and that's based on grade C evidence. Here's another one that gets called out by name: low-level laser therapy. Now, despite how popular this is in some clinics, the 2024 guidelines are very direct. It should not be used for this specific type of Achilles pain. And what about therapeutic ultrasound? Okay, pay really close attention to that word alone here. The evidence shows that as a standalone treatment, it's no better than a placebo. It should not be the primary focus of your recovery. Okay, we have covered a ton of ground. We've defined the problem, we've walked through the diagnosis, and we've separated the treatments that work from the ones that, well, don't. So let's put it all together into an actionable roadmap for you. So if you remember anything, remember this: your story, your symptoms, that's what matters most for diagnosis. Exercise is king. Don't stop moving completely. Be a little skeptical of those passive treatments. And most importantly, you are now equipped to be an active, informed partner in your own recovery. And we'll leave you with this question to think about. Just take a look at your current approach. Is it centered around progressive loading and exercise? Or is it maybe relying on some things the evidence says we should be pretty cautious about? Now you have the 2024 expert consensus to help you find the right path forward.